All right, diving in today on low back pain.
Oh, yeah, real classic.
Familiar foe for all of us in general practice, right? You know how it goes. Patient walks in, points right to their lower back, and they're like, "Doc, it hurts." But you and I both know there is a whole universe of possibilities behind that one little complaint.
It's true. And while most cases, thankfully, are going to be benign, there's always that little bit of serious conditions that we need to make sure we're not missing.
Exactly.
Yeah.
That's why having a system is so crucial, especially for, busy GPs.
Yeah, gotta have that system down.
So in this deep dive, we're going to try to equip you with a really practical framework for assessing low back pain. So we can figure out, is this something I should be worried about, or is this something that's probably going to resolve on its own?
Yeah, and we're going to go a little bit beyond diagnosis. We'll get into the latest evidence and guidelines on managing those specific conditions that we're going to talk about, so you can walk away feeling confident and ready to tackle those back pain cases.
Perfect. Love it. Now, before we get in the nitty-gritty, let's just paint a picture of how big of a problem this really is. I was looking at some data, and it's honestly pretty wild how common this is.
Yeah, it really is. The studies show that a huge percentage of adults are going to experience low back pain at some point in their lives. We're talking like upwards of 80%.
Wow.
And for those of us in primary care, I mean, this is one of the most common reasons our patients are coming to see us.
It's a constant, in our daily practice.
Oh, for sure.
And it's not just a quick fix either.
Yeah.
Low back pain can really impact a person's whole life, right?
Mhm.
Their work, their activities, their mental well-being.
Absolutely. That's such a good point. We're not just treating pain here, we're treating a whole person. And we need to see the whole picture of their lives and how this back pain is fitting into that.
Okay, so we've established it's common, it's complex, it impacts people's lives.
Yeah.
Let's talk about risk factors. Who's most likely to end up in our office with this issue?
Well, like you said, it's complex. It's not one size fits all. But there are definitely certain factors that increase the likelihood of low back pain. I like to think about this using the acronym SMOKE.
Smoke.
Yeah, I know it's kind of quirky, but it helps me remember.
I like it. All right, break it down for me.
Okay, so S stands for smoking. Obviously, we know that smoking impairs blood flow, weakens those bones, and it just makes the spine more vulnerable to injury and degeneration.
Yeah, makes sense. It's just another thing to tell our patients to quit smoking about,
Uh,
even if we get the eye roll.
oh, for sure.
Okay, what about M?
M is for mechanical stress. Jobs that involve heavy lifting, repetitive motions, or even just prolonged sitting can really take a toll. And those weekend warriors who go out and try to do yard work they haven't done all year.
Oh, I know them.
Yeah,
Monday morning, they can barely walk.
exactly. So we've got smoking, we've got mechanical stress. What about O?
Oh,
Which stands for obesity. And we know excess weight just puts added strain on the spine, and that, of course, increases the risk for pain and injury.
yeah, it's like carrying around an extra backpack 24/7. It's going to
Yeah.
lead to problems.
Absolutely. So we've got smoking, mechanical, obesity.
Yay.
K is for cancer history. So that's one of our big red flags, right? If we have a patient who comes in with a past cancer diagnosis and they've got new or worsening back pain, we need to be extra cautious.
Because it could be a sign of metastasis to the spine.
Exactly. And some cancers are more likely to spread to the spine, like prostate, breast, lung cancer.
Okay, yeah, so those are patients that we're really going to
Yep.
keep a close eye on. Okay, last letter in smoky. What is it?
E, this one's for emotional distress.
Okay.
Things like depression and anxiety can actually amplify pain perception, and that makes it harder to cope with the back pain.
Oh, interesting.
And we can't forget about the psychosocial factors too, right? Job dissatisfaction, financial stress, even just a history of failed treatments can all play a role.
Wow, that's a lot to think about. I love smoke, though. I'm going to remember that.
Yeah.
It's a nice little mental checklist. All right, so we've got smoking, mechanical, obesity, cancer history, and emotional distress. It's really going to help assess that overall risk and figure out how we should tailor our evaluation.
Absolutely.
Okay, let's get into the different types of back pain. Because as we know, they're not all created equal. How do we start to tease apart, the everyday aches from the stuff that we should be worried about?
Right. Well, most of the time, the vast majority of cases, what we're going to see is what we call non-specific low back pain.
Okay.
Meaning, there's no clear identifiable cause. It's probably some musculoskeletal issue, like a muscle strain or a ligament sprain.
So it's good old, I lifted something heavy or I slept funny.
Exactly. That's the one. And the good news is most of these cases, they tend to get better within a few weeks, just with some conservative
But
management.
it's reassuring.
Yeah.
But then there's that other category, right? The less common, but much more worrisome causes that we've got to be on the lookout for.
Right, those red flags that should really heighten our suspicion. They're less common, statistically speaking, but we can't let our guard down, right? Especially when a presentation just doesn't seem quite right.
All right, well, let's get into those red flags. What are the top conditions that should be on our radar?
Yeah. So number one, always got to think about Cauda-Equina syndrome.
Okay.
This is a rare one, but it can be devastating. It happens when the bundle of nerves at the lower end of the spinal cord gets compressed.
Oh, wow. And that compression can have some pretty serious consequences if it's not caught, right?
Oh, absolutely. If it's left untreated, it can lead to permanent neurological damage. You're talking paralysis, incontinence. That's why recognizing it early and intervening quickly is absolutely crucial.
Okay, so what are the signs? What are the things that should make us think Coda equina? What should we be asking our patients about?
So the classic triad of symptoms is severe low back pain, bowel or bladder dysfunction, and then saddle anesthesia. That's the loss of sensation in the, area that would touch a saddle.
Saddle anesthesia.
Oh,
Okay, so those urinary or fecal issues, those are big red flags. We can't ignore those.
absolutely. And then any new onset weakness or numbness in the legs, especially if it's progressive, that should also be setting off alarm bells.
Okay, so bowel, bladder issues, saddle anesthesia, and any new neurological problems in the legs. Got it. What about the physical exam? Are there specific things that we should be doing to check for Cauda equina?
Oh, yeah, definitely. A thorough neuro exam is essential. We're going to focus on testing sensation in that perineal area and assessing rectal tone. We also want to check for lower extremity weakness, particularly the ankle dorsiflexors and plantar flexors.
Okay, so if we find any of those signs, we are sending them straight to the ER for an MRI.
Absolutely. No hesitation in those cases. Time is really of the essence with Cauda-Equina.
Okay, Cauda equina, definitely top of the list.
Right.
What's the next condition we need to be thinking about?
So let's talk about metastatic cancer, another one that we need to be really careful about, especially in patients who have a history of cancer.
Right, and we talked about that a little bit with our SMOKE acronym.
Yeah, exactly.
So what are we looking for specifically in those patients?
So we need to really pay attention to the character of their pain, right? Is it constant? Is it worse at night? Does it get worse even when they're resting? Those are all red flags that could suggest a tumor.
Yeah, I imagine any sudden or significant worsening of their pain would also be really concerning, right?
Absolutely. Especially if it's accompanied by any neurological symptoms like weakness, numbness, or tingling.
Okay, so it's not just the pain itself, it's the pattern and what other symptoms are going along with it.
Right.
What about physical exam findings? Anything specific that would make us think cancer?
Yeah, tenderness to palpation over the spine is always something that we're going to note. And then, of course, any neurological deficits like weakness or those sensory changes would make us really worry.
So if we suspect metastatic cancer, what do we do?
We got to get imaging. An MRI is usually our go-to. It's going to give us the best view of the spine and see if there are any lesions.
Okay, so Cauda equina, metastatic cancer, two serious conditions that we have to catch early. All right, what's the third red flag that we should be keeping in mind?
So number 3, we have a spinal epidural abscess. This is an infection that develops in the space between the spinal cord and the vertebrae.
An infection in the spine. That sounds incredibly dangerous.
Oh, it can be, especially if it's not caught early. Like Cauda equina, a spinal epidural abscess can compress that spinal cord, and that can lead to some permanent damage.
So what are the signs and symptoms here? What clues would tip us off that we might be dealing with a spinal epidural abscess?
Yeah, this one can be tricky because the early symptoms are very nonspecific. Patients might have fever, chills, just general malaise, things that you might easily mistake for just a regular cold or flu.
Okay, so not your typical back pain presentation then.
Right. But as that infection progresses, that back pain is going to become more prominent and it's going to be more localized. And then they might start to develop those neurological symptoms too, like weakness, numbness, or even problems with their bladder or bowels.
So those neurological issues, again, seems to be a common thread with these serious back pain conditions.
Exactly. And it highlights how important it is to do a good neurological exam on everyone who comes in with back pain, especially if they've got fever or other signs of an infection.
All right, so who's at risk for this? Who should we be most concerned about developing a spinal epidural abscess?
So anyone with a weakened immune system is at higher risk. That includes folks with diabetes, HIV, or anyone on immunosuppressant medications. We also need to be careful with patients who've had recent spinal procedures like injections or surgery, because that can sometimes introduce bacteria.
Okay, so their medical history is playing a big role here in our
Oh,
assessment.
absolutely. And then, of course, IV drug use is a major risk factor for a spinal epidural abscess.
Okay, so we're thinking about immune status, recent procedures, and IV drug use.
Yeah.
And if we're suspecting a spinal epidural abscess, what do we do?
Same thing as with cauda equina, we need to get imaging right away. An MRI is going to be the gold standard here. It lets us diagnose the abscess and see how bad it is.
Okay, so there we have it, our big three red flags. Cauda-Equina syndrome, metastatic cancer, and spinal epidural abscess. These are the ones we need to jump on right away.
Exactly. These are not wait-and-see situations. Recognizing these early and treating them aggressively can make all the difference.
Okay, well, let's shift gears a little bit. Now let's talk about some of those less serious but still important causes of low back pain. Where should we start?
Well, let's start with something that we see pretty often, vertebral compression fractures. Those can be a real pain, literally, for our patients.
Oh yeah, compression fractures.
Mhm.
Now, I always think of those as being caused by trauma, like a fall or something.
Yeah, trauma is definitely a common cause, especially in younger people. But in older adults, especially women, osteoporosis is often the culprit. Those Winkin bones can fracture even with minor stress, or sometimes even spontaneously.
So we're really thinking about osteoporosis, especially as our patients get older.
Oh, yeah, for sure.
Okay, so how do these patients present? What's the pain like?
It's usually a pretty sudden, sharp pain. It's very localized to the area of the fracture, and it can be quite debilitating. Bending, lifting, even just moving around can make it a lot worse.
Yeah, I can imagine. What about the physical exam? Anything specific we should be looking for?
Well, point tenderness over the affected vertebra is a key sign. And depending on how bad the fracture is, we might see some postural changes like kyphosis. That's that rounding of the upper back.
Okay. So if we're thinking compression fracture, is imaging our next step?
Yeah, usually plain radiographs are going to be our first line. They can confirm the diagnosis, show us where the fracture is and how bad it is.
And if the x-rays don't show anything, but we're still suspicious?
Then we might need to consider an MRI or a bone scan to rule out other things or just get a better look.
Okay, so compression fractures,
Yeah,
definitely something to keep in mind, especially in our older patients.
absolutely.
All right, what's next?
Let's move on to radiculopathy. This is a condition that affects the nerve roots as they exit the spinal cord.
Radiculopathy.
So this is where we start talking about things like sciatica.
Exactly. Sciatica is one of the most common types of radiculopathy. It's when those L5 or S1 nerve roots are affected. But radiculopathy can happen at any level of the spine, and the symptoms are going to vary depending on which nerve root is involved.
Okay, so what are some of the common causes of radiculopathy? What are the things that are compressing those nerves?
Herniated discs are a big one. That's when the jelly-like center of a disc bulges out and presses on a nerve root.
Ouch, I bet that hurts.
Yeah, it does. And then spinal stenosis is another common cause, especially in older adults. That's where the spinal canal itself starts to narrow and compresses those nerves. And then you have things like bone spurs, tumors, even infections that can cause it.
Wow, so there are a lot of things that can go wrong there.
There are.
So how do these patients present? What's the typical story?
So the hallmark of radiculopathy is pain that radiates along the path of the affected nerve. So with sciatica, for example, you're going to see that pain shooting down the leg, often all the way to the foot. And the pain, it's not just a dull ache, right? It's more of a sharp, shooting, electric kind of pain.
Yeah, exactly. And it's often accompanied by other neurological symptoms too, like numbness, tingling, or weakness in the leg.
So we're listening for those descriptions of radiating pain, asking about any numbness or tingling. What about the physical exam?
Mm-hmm.
Any tests that can help us pinpoint which nerve root is affected.
Yeah, the straight legs raise test is a classic. You have the patient lie on their back and you slowly lift their leg up. If it reproduces their leg pain, that's a positive test. It suggests that there's some nerve root compression.
Okay, classic straight leg raise, and of course a good neuro exam, checking reflexes, strength, and sensation in that leg.
Right, we're looking for weakness, sensory loss, or changes in reflexes that match up with the nerve root we think is involved.
Okay, so we've got our history, our physical exam findings, maybe even a positive straight leg raise. What's next? Do we need to get imaging?
Yeah, usually at that point, imaging is warranted. An MRI is often the best choice here because it gives us a really clear picture of the discs, the nerves, and everything else that's going on in the spine.
And on that MRI,
Yeah.
what are we looking for specifically?
We want to see if there's any evidence of nerve root compression, whether it's from a herniated disc, spinal stenosis, or something else.
Okay, so radiculopathy, another common one to keep in mind, especially since it can cause both back and leg pain.
Yeah.
For sure. What else should we have on our radar?
Well, let's talk about spinal stenosis, which we briefly touched on when we were talking about radiculopathy,
Okay.
but it really deserves its own attention because it's a major cause of back pain, especially as people get older.
Okay, spinal stenosis. Remind me again, what is that exactly?
So it's where that spinal canal narrows, right?
Right.
And it's usually a gradual process that happens as we age. The discs can lose height, they can bulge out, the ligaments can thicken, and the bones themselves can even develop arthritic changes.
So it's like this slow, steady encroachment on that space where those nerves travel. Oh.
Exactly. And as that space gets smaller and smaller, those nerves get compressed. And that leads to a bunch of different symptoms.
Okay, so what are those symptoms? What are we going to see in a patient with spinal stenosis?
Back pain is a common one, of course. But the leg pain is really what sets spinal stenosis apart. It's often described as a cramping, aching, or burning sensation that comes on with walking or standing.
And that's what we call pseudoclaudication, right?
Exactly. It mimics the pain of vascular claudication, which is caused by poor blood flow to the legs. But with pseudoclaudication, the pain is coming from that nerve compression, not the circulatory system.
So how do we tell the difference? How do we know if it's nerve pain or vascular pain?
Well, one of the key things to look for is that positional relief that patients with spinal stenosis get. Their leg pain often gets better when they lean forward, sit down, or even bend over a shopping cart.
Oh, that's interesting, because those positions actually open up the spinal tunnel a bit and take some pressure off those nerves.
Exactly. That's kind of a hallmark of spinal stenosis.
Okay, so we're listening for that leg pain that gets worse with walking or standing, gets better with leaning forward or sitting. What about the physical exam? Anything specific we should be looking for?
Yeah, we might see some weakness in the legs, especially after they've been walking for a while, and the reflexes in the legs can sometimes be diminished. But a lot of times, the neuro exam is pretty normal, even in patients with pretty significant stenosis.
So it sounds like the history is really our most valuable tool here in diagnosing spinal stenosis.
Often it is. And if the history is pointing us in that direction, we can confirm the diagnosis with imaging. An MRI is usually the best option. It shows us how much narrowing there is and what else might be contributing to it, like disc herniations or bone spurs.
All right, so spinal stenosis is another one to keep in mind, especially as our patients get older.
Definitely.
Okay, what else?
Let's talk about axial spondyloarthritis. This is a type of inflammatory arthritis that mainly affects the spine.
Inflammatory arthritis. So now we're thinking autoimmune conditions.
Right. Axial spondyloarthritis, which includes ankylosing spondylitis, is a chronic inflammatory disease. It can cause pain, stiffness, and eventually even fusion of the spinal joints.
And this one typically affects younger patients, right?
Yeah, it usually starts in early adulthood, often in the late teens or early 20s.
Okay, so how does this present? What should make us think of axial spondyloarthritis?
So the hallmark of inflammatory back pain is morning stiffness that gets better with exercise. Patients will tell you they feel stiff and achy first thing in the morning. It takes them a while to loosen up.
And that's different from mechanical back pain, which usually feels worse after activity.
Exactly. With inflammatory back pain, movement actually helps. And the pain is often worse at night, sometimes even waking them up from sleep.
So morning stiffness, pain worse at night, and improvement with exercise. Those are kind of our red flags for inflammatory back pain.
Right.
What about physical exam? Anything specific we might find?
Yeah, we might see a limited range of motion in the spine, especially in the lower back, and tenderness over those sacroiliac joints is common too.
Okay, so we've got the history, we've got the physical exam findings. What's our next step if we're suspecting axial spondyloarthritis?
Well, blood tests can be helpful. We might check for inflammatory markers like ESR and CRP, which are often elevated. And there's a specific blood test called HLA-B27 that's strongly associated with this condition.
So the blood tests can help us support the diagnosis. What about imaging? Do we need x-rays or an MRI?
X-rays can be helpful, especially in the later stages of the disease when you might start to see changes in those sacroiliac joints or the spine.
Hmm.
But early on, the X-rays might be normal. An MRI can sometimes pick up the inflammation earlier in the disease process.
Okay, so axial spondyloarthritis, another one to keep on the differential, especially in those younger patients with back pain. That's just not going away.
Right.
All right, are there any other less common causes that we should touch on before we move on to management?
Yeah, there are a few other things to think about, although they're not as common as the conditions we've already talked about.
Okay, let's hear them. We want to be thorough. All right.
Right. So piriformis syndrome, where a muscle in the buttock compresses the sciatic nerve, can mimic sciatica. And sacroiliac joint dysfunction, where the pain is coming from that sacroiliac joint in the pelvis, can also cause low back pain.
Wow, so many potential culprits. It really highlights how important it is to do a thorough history and exam.
Oh, yeah, for sure.
And I'm sure there are even times when that pain is coming from somewhere else entirely, right?
Yep.
Like maybe a kidney stone or a pelvic infection.
Absolutely. We always need to keep that broad differential in mind and not get tunnel vision on the spine. Sometimes the back pain is just referred pain from something else going on.
Great point. Okay, well, we've covered a lot of ground here, from those urgent red flags to the more common, less serious causes of back pain. Now, let's shift gears and talk about management. What are the general principles that we should be following when we're seeing a patient with back pain?
Okay, so first and foremost, I think reassurance is key. Remember, most cases of low back pain are benign and self-limited. They're going to get better on their own with a little time and some conservative measures. So we need to reassure our patients that we're taking their pain seriously, but we don't think it's anything dangerous.
Reassurance, that's a big one. We don't want to make them more anxious than they already are. What else?
Encouraging activity is crucial. Bed rest is actually bad for back pain. We want our patients to stay active as much as they can tolerate.
So even if it hurts a little, it's better to keep moving than just lie around in bed.
Exactly. Gentle stretching, walking, and other low-impact activities can actually help them recover faster.
Okay, reassurance, encourage activity. What about meds? What are our go-to pain relievers for back pain?
Usually, over-the-counter pain relievers like acetaminophen or ibuprofen are a good place to start. They work well for most patients. And if those aren't doing the trick, we might consider a short course of muscle relaxants or even a low-dose opioid. But we always want to use opioids carefully, of course.
Of course. We want to avoid those risks of dependence and long-term use. So what about the patients who don't get better with just those basic measures? When do we start thinking about other options?
So if the pain is hanging around for more than a few weeks and those initial measures aren't helping, then we might think about referring to physical therapy. A good PT can teach them exercises to strengthen their core muscles, improve their flexibility, and reduce their pain.
Physical therapy, it's amazing how much of a difference that can make.
It really can. And then for patients with radiculopathy, we might consider an epidural steroid injection. This is where we inject a corticosteroid medication into the space around the affected nerve root to reduce inflammation and pain.
Epidural steroid injections, those can be pretty effective, but they're not a permanent fix, right?
Right. They can provide temporary relief, but they don't really address the underlying cause of that nerve compression.
So for some patients, we might eventually need to think about surgery.
Yeah, surgery is definitely an option for some conditions, like a herniated disc or severe spinal stenosis that's not responding to other treatments, but it's always a last resort.
Okay, so we've got our conservative measures, physical therapy, injections, and surgery as potential tools in our toolkit. And let's circle back to imaging, because I think there's more to unpack there.
Yeah.
We know most patients with acute low back pain don't need imaging right away. But how do we decide when it is time to get those x-rays or an MRI?
Yeah, that's the million-dollar question, and it's a question we get a lot in primary care. The good news is there are evidence-based guidelines that can help us make those decisions.
Ah, guidelines, always helpful. What are some of the key things that should be influencing our decision to order imaging?
Well, first and foremost, we need to think about those red flags we talked about earlier. Any signs or symptoms that point to cauda equina syndrome, metastatic cancer, or a spinal epidural abscess, we're getting imaging right away.
Okay, so those are automatic imaging referrals. What about less urgent situations?
If the pain is really severe or it's just not getting better despite those conservative measures, then we might consider imaging. And if there are specific things that concern us, like neurological deficits or a history of cancer, that would also make us more likely to order imaging.
So it sounds like it's a judgment call based on the individual patient, their risk factors, and how they're responding to treatment.
Exactly. And it's a decision that we should ideally make together with our patients. We want to explain the risks and benefits of imaging and make sure they understand why we're making the choices we're making.
Shared decision-making,
Mm-hmm.
always the best approach. All right, let's wrap up this section with some practical tips on how we can talk to our patients about back pain. Because, as we all know, they often come in with a lot of anxiety and misconceptions.
Yeah, communication is so important. We need to really listen to their concerns, validate their pain, and explain things in a way that they can understand. And that includes being upfront about the limitations of imaging.
Right, we need to dispel that myth
Yeah.
that an MRI is going to give us all the answers or offer some quick fix.
Exactly. We need to emphasize that most back pain gets better on its own, and that imaging often isn't necessary or even helpful.
And I imagine it's also helpful to set realistic expectations about treatment. We can't always make the pain completely go away, but we can help them manage it and get back to doing the things they enjoy.
Absolutely. And we need to be honest about the potential risks and benefits of those different treatment options, whether it's medication, physical therapy, injections, or even surgery.
Okay, so we've talked about red flags, those less serious causes, and kind of our general approach to managing back pain. But I think there are some nuances to imaging that we could unpack a little bit more because, imaging can be a bit tricky.
Oh, it definitely can. And the guidelines, while helpful, don't always give us like a perfect answer for every single situation.
Right.
We still have to use our judgment and really think about the patient in front of us.
For sure. So let's walk through a few scenarios. Say we've got a patient who comes in with acute low back pain, no red flags, but the pain is pretty severe. They're really hurting, and they're asking for an MRI. They want to know what's going on. How do we handle that?
Well, I think it all comes down to communication, right? We need to
Right.
acknowledge their pain and that they want answers. But at the same time, we need to explain that in most cases, imaging for acute low back pain, it's not going to change how we manage
Right.
things.
So we're not dismissing their pain, but we're saying an MRI may not give them the answer they're looking for.
Exactly. And we can reassure them, right? We can say, look, if your pain doesn't improve with these other things we're trying, imaging is always an option down the road.
Okay, that makes sense.
Yeah.
What about those patients with subacute back pain? So it's been going on for a few weeks and it's not getting any better.
Yeah.
When do we start thinking about imaging in those cases?
Yeah, so if it's been like 4 to 6 weeks and they're really not responding to conservative treatment, that's a reasonable time to consider it,
Yeah.
especially if there's some specific things that are making us worry, like neurological deficits or signs of radiculopathy.
Right. So, for example, if they've got persistent sciatica that's just not budging, an MRI might be helpful to see if maybe there's a herniated disc or some spinal stenosis that we could potentially address with surgery or an injection.
Exactly. But again, it's not automatic.
Like,
We always have to weigh the benefits of imaging against the risks. And one of those risks is incidental findings, things that might lead to more testing and more anxiety, even though they're not really causing a problem.
yeah, those false positives can be tricky. Okay, last scenario. Patients with chronic back pain, folks who've been dealing with this for months or even years. Is imaging helpful in those cases?
It can be, but it's even more nuanced, right? We have to think about what's already been done, what their goals are, and whether imaging is actually likely to change how we approach their treatment. If they've already had multiple imaging studies that haven't shown anything significant, another MRI is probably not going to tell us much.
Right. It's about being selective and using imaging when it's really going to make a difference.
Exactly. And I think the important thing to remember is imaging, it's just one piece of the puzzle. It doesn't tell us everything. We need to take into account the whole picture, their history, what we find on the exam, and their overall clinical presentation.
Makes sense. Well, I feel like we've really covered a lot of ground today on low back pain.
We have. It's been a good discussion.
We talked about those red flags, the common causes, all sorts of management strategies, and really dove deep into the whole imaging dilemma. So to our listeners out there, I hope you found this deep dive as useful as I have. Remember, you are equipped to handle low back pain. You've got the tools and the knowledge. And stay tuned for our next deep dive, where we'll be tackling another common challenge in general practice. Until then, keep learning, keep questioning, and keep taking great care of your patients.